Thanks for joining. Um, my name is Aoife van Hastern. I work at Roche Diagnostics, and I lead data and digital policy. Thank you very much for joining us today. Welcome. Good morning, good afternoon, wherever in the world you are. Um, Roche is really committed to building digital health solutions because we've recognized that there are several health system pain points, not exclusive to shortages in workforce, their rising cost, high burden of non-communicable diseases, amongst others. And we recognize digital solutions have a huge impact in moving the needle for these challenges. Now, due to this, we are building solutions for patients, for labs, and for physicians. And like many organizations that are involved in this endeavor, we have recognized several shortcomings that's making it extremely challenging to get these products to patients. Now, these are particularly for physician-facing solutions, and especially when they're AI-enabled. And so due to this challenge that we identified, we decided to join forces with LSE to work out on coming up with a proposal for a taxonomy, as well as a value assessment framework, which we will present here today. Ultimately, Roche is committed to really getting these innovative solutions to patients, but also working hand in hand with policymakers to address the challenges that currently stand in the way. And so with that, I'll hand over to Robin from LSC, who will walk us through the report, and then also follow this with a panel discussion. So thanks again for joining us, and I'll hand it over to Robin.
Welcome everyone to this webinar on the launch of the report on evaluation framework for health professionals, digital health and AI technologies, along with the evidence-based policy recommendations. My name is Robin van Gessel. I am the Hoffman Fellow between the London School of Economics and the World Economic Forum, and the founder of the Digital Health and AI Research Unit here at the London School of Economics. Today, in the next 10 minutes, I'm going to walk you through the overarching findings of the report, the link of which will be shared with you after this webinar is completed. And once this presentation is done, again, it's about 10 minutes, we will go into a very exciting panel discussion with panelists that I will present to you and I will introduce after the presentation is finished. So first, to set the scene, healthcare systems are in dire straits. They are pressured by financial commitments of financial constraints with competing priorities, acceleration of shortages in healthcare workforce, and rises in communicable, non-communicable diseases, aging populations, and you name it. It's very well documented by the World Health Organization. At the same time, a new archetype of technologies has entered our health systems, namely digital health and AI technologies, that claim to be able to address these challenges. And according to the World Health Organization, investing today an additional 24 US dollar cents per patient per year in digital health interventions could save more than 2 million lives from non-communicable diseases over the next decade, lead to an additional almost 200 billion in economic benefits, and prevent approximately 7 million acute events and hospitalizations. Now, why don't we jump immediately on this? Well, that's one of the topics of today's webinar. We continue to face implementation challenges ranging from individual skills to insufficient funding, infrastructures for deployment, and regulatory problems. There is also a limited amount of evidence on the real-world impact of digital health and AI technologies, meaning that the discourse around these technologies is largely dominated by promises, not evidence. And that results in technologies being marketed that are capable of this: a chatbot telling a recovering drug addict to take some drugs because of insufficient quality control, or an AI-powered tool wiping out an entire code database, an entire database. Imagine that happening to your hospitals. Where are you then? So quality control and evidence generation pipelines are incredibly important, but we don't have them fit for purpose. Why not? Well, evaluation processes for these technologies are derived from pharmaceuticals and medical technologies. They're so far heavily skewed towards patients, often ignoring medical professionals or spending insufficient time on the unique needs of medical professionals, healthcare professionals. And that results in limited usability of these frameworks due to these digital health and AI technologies also evolving as their deployment ongoes, their rapid rate of technological innovation, and the difficulty of finding comparators against which they can be benchmarked. So far, we've seen some initiatives trying to develop evaluation frameworks, notably SSDHT and EDITA, that are focusing on harmonizing rather than developing an entirely new framework for digital health technologies and AI technologies within the context of the European Union. However, they don't necessarily address professional-facing technologies because that can mean a lot of things. And it also remains unclear how this heterogeneity of professional-facing technologies is actually embedded in current evidence generation frameworks. So we did an investigation at the London School of Economics with support from Roche Diagnostics, and we mapped 6 countries. We investigated 6 countries, performed a comprehensive literature review to create a taxonomy and to understand how digital health and AI technologies, especially those for healthcare professionals, are embedded within current risk and purpose-oriented frameworks. And what we found was that the mapped countries being Germany, France, the United States, Canada, South Korea, and the United Kingdom, they by and large align their classification framework with that of the International Medical Device Regulatory Forum, the IMDRF, though some discrepancies, some national variations in scope exist. Overwhelmingly, the requirement of oversight and the requirement for evidence is proportionate to the potential harm and the risk profile of the technology. And the scope of medical devices generally comprises a combination of diagnostics, prediction, monitoring, treatment, using clinical data or providing critical clinical information. And that's really important because currently digital health and AI technologies are often described under the umbrella of software as a medical device, a specific archetype of medical devices. There are, as I said, some country-specific classifications that are specifically related to digital health and AI technologies, such as the UK having their three-tiered early value assessment framework that distinguishes between system well-being and medical or clinical technologies. France has a similar framework, but adds an additional 4th layer for those technologies capable of autonomous decision-making. The United States does not incorporate a clear framework as the UK or France does, but generally outlines the boundaries of what is considered a clinical decision support system that falls within or without the FDA oversight. Germany generally aligned with the IMDRF, but includes a more evaluation and reimbursement innovation in their DIGA, the digital health law, digital health law that they passed in 2018, 2019. South Korea differentiates machine learning applications based on potential risk, though does not explicitly delineate what those risks are and what the criterion are. Potential patient harm is one of them, but a comprehensive framework is still being developed, I would assume. And finally, Canada adds a functional distinction between medical grade AI and consumer health applications, but does not expand much further. Point being that a lot of these frameworks are in their infancy. They're the first generation of frameworks that look to navigate a rather mysterious and emerging field. And these are very much prone to change. So, as I said earlier, the majority of digital health and AI technologies that have been granted access in the EU and the United States are classified under software as a medical device umbrella. In the EU, they're overwhelmingly labeled as Class 2A medical devices or low to medium risk. And in the United States, they're overwhelmingly labeled as low risk devices as well. Now, with the introduction of the EU AI Act, which deserves a mention, the market access pathways of these technologies will change. Systems with AI systems in regulated digital medical products, such as those in AI medical devices, are likely to now be classified as high risk under Rule 11 of the AI Act and the interaction with the medical device regulation. At the same time, the other regulations, such as medical device regulation, in vitro diagnostic devices regulation, will continue to apply, and their interactions are not always clear, and there are currently projects ongoing to identify and explain those interactions. Now, our contribution within, that was a lot of scene setting, our contribution with this project is going to be twofold. One, we present in the next slide a evidence-based taxonomy for professional-facing digital health and AI technologies that's based on 7 dimensions: intended beneficiary, intended use case, intended impact, the data inputs that are necessary for the technology to be trained and to operate, the driving technology, whether that be static or probabilistic in a form of an AI, the way that the technology can be accessed, and the degree of interoperability that the technology brings with it. Now, what does that look like? Well, we created a bottom-up framework. So we started with the intended beneficiary, which could be, for example, a primary practitioner, secondary care physician, tertiary specialist, nurses, or other healthcare professionals. And we worked our way up layer by layer by layer by layer, adding dimensions where quality could be assessed, where distinctions between different digital health and AI technologies could be made across primary care physicians, across hospital settings, across non-clinical settings, but in a way to map this heterogeneous field. So the idea of this framework then is, instead of assessing a healthcare professional facing technology, is that we compare apples to apples. We compare a technology that is accessible through a browser, that is driven by an AI technology, and that is built and that operates on the use of electronic health records, with other technologies that fall within that category. Now, this framework is not exhaustive, nor is it comprehensive. This is a building blocks framework, and the idea is that as the field matures, these building blocks change, they're updated, they're added, they're subtracted where they're no longer used, and forms a starting point to open the discussion for consistent evaluation metrics or evaluation protocols. Subsequently, we looked into evidence generation documentation in these 6 countries. And unsurprisingly, randomized control trials are a fan favorite. They are the gold standard across all 6 of these countries. But alternative methodologies are gaining recognition and acceptance, such as observational studies and pragmatic trials in the UK, randomized consent trials, target trials in France, and real-world data and adaptive trial designs in Germany, France, and South Korea. Similarly, when we look at the endpoints for economic evaluations, France and the UK explicitly mention that a cost-utility analysis is considered the standard that they require, but that cost minimization and cost consequence analyses, other forms of health economic evaluations, may be used if they are appropriate. In terms of evidence thresholds and uncertainty, the United States and South Korea accept a standard of substantial equivalence, which means that if a newcomer, a new technology, operates in a similar fashion for a similar population group as a technology already on the market, then based on that equivalence, it can be granted access to the market. And as for France, France suggests the use of what we consider Bayesian analysis, a probabilistic form of data analysis for communicating uncertainty estimates, which is particularly relevant for digital health and AI technologies, given a lot of these technologies are probabilistic in nature. And it offers the inherent mechanism to update results as new data comes in. Now, there have been some initial initiatives to monitor the post-deployment phase of AI technologies. Canada and South Korea implemented post-market surveillance and change approval requirements. South Korea explicitly states that it exempts change approval and certification if additional training data is added, and if the manufacturers manage both the training and the device performance through their quality management system. And in the United States and the European Union, the pre-approved control change plans for AI medical technologies are considered a possibility now as part of the evaluation, which offers the ability to preemptively approve predicted changes in AI systems. Now, to round off the scene setting and to move into the panel discussion, different AI models and different digital technologies require different inputs and produce different forms of outputs. These technologies are not considered a monolith, even if we can bring them under a single umbrella like medical devices or AI medical devices. Novel research designs may ease digital health impact assessments across different populations. They can slightly warp the way that evidence generation is conducted, but these research designs currently have limited suitability to assess healthcare professional-facing technologies, given their focus on patient-facing outcomes. Plus the fact that AI technologies may evolve over time, which is inherently contradictory to the rather static state of regulatory and assessment protocols. And we see a convergence of regulatory approval and value assessment processes that may benefit evidence generation in the long run, given that there's less splintering of the processes. And with that, thank you very much. And we'll move now into the panel discussion. So today's panel, I am very excited to present, first of all, Professor Jochen Klucken, the Chair of Digital Medicine and Head of the Digital Medicine Research Group at the University of Luxembourg. I am happy to have with us George Wharton, the Associate Professor in Education at the Department of Health Policy at the London School of Economics, Dr. Chaoyi Guo, the Head of Clinical Validation and Roche Information Solutions at Roche Diagnostics. We have Dr. Katarzyna Markiewicz-Barrow, AI Strategic Intelligence Lead in Philips and the HTA Committee Co-Chair at MedTech Europe, and Antonio Spina, the Digital Health and AI Lead at the World Economic Forum. So to kick off today's panel, Professor Jochen Klucken, can I please ask you, we hear a lot about the wonderful potential of digital health and AI technologies, though evidence of its impact is often somewhat limited due to, for example, the factors raised in the introductory presentation. What is the perception of these technologies on the clinical side, and what evidence or insights, if anything, are missing from the conversation?
Yeah, Robin, first of all, let me thank you in particular for generating this report. And I've read it, and I can only encourage everyone here in the audience to really read it, because it's such a variety and a lot of information, perspectives on what AI can do to healthcare. So I really, really enjoyed reading it. And I think your question is well taken. What can we do to make it possible, basically? And I see in a way, there's two aspects that have to be addressed, and both aspects rely on the fact that AI can actually really help us in our clinical decisions. And if it does so, it requires an acceptance. So one aspect that is really, really important here is the trust of healthcare professionals using these type of technologies. We will be overrun by patients using these technologies, getting a good clinical decision support, and then they go to the doctor and say, hey, the system told me to do this and that, and please help me here. So doctors right now, they do not know how to handle this. A lot of education is needed, building trust on healthcare professionals to really use these AIs. So this is one part of the answer. And the second part, maybe briefly, is the evidence that it's really generating impact. Typically, AI for healthcare professional facing is good in arguing what is the precision and accuracy of a given prediction. And here, precision and accuracy probably is not enough, because we have to test in clinical studies that this leads to an impact and also monitor the side effects. So these two aspects, I think, acceptance and trust in using AI, but also building methods, and they are different from what we know from, let's say, pharma trials. That building methods is really an important part that convinces healthcare professionals to really use it. And last but not least, of course, we have to define the role of, let's say, medicinal societies, how they could be involved in this. Because typically the doctor, and I'm a doctor in the end, is used to make guidelines for healthcare procedures. And now this is taken over by AI, and we need to find our place here. So this is definitely an aspect, get the healthcare professionals more involved.
Thank you very much. And to kind of move ahead on the point of generating the evidence of impact, and I'll move for this to George, one would think that given the lofty promises around these technologies, health systems would jump at the opportunity to figure out if the promises are real, to generate that evidence. Why are we so reluctant to modify, even in a pilot setting, there's these assessment protocols to measure what the performance and the impact is?
Yeah, it's a great question. And I think that an easy and probably rather flippant answer to that is that it's simply because it's hard to do. And there probably is an element of truth in that. But everything that Professor Kluken mentioned holds true here. You know, developing the methods takes time. It's going to take time to get stakeholders aligned. But to be a bit more precise, I think the inertia that we're seeing reflects the fact that for an individual technology or class of technologies, you know, regulatory approval, health technology assessment, adoption decisions, reimbursement requires alignment across multiple stages, and that isn't going to arise spontaneously. You know, there's a challenge and a problem of coordination here. And I think it's probably that rather than what you implied in your question, which is that it's about reluctance, right? No single actor is responsible for the whole process. Each gatekeeper maintains its own standards independently, and there frankly isn't enough alignment in incentives or interests across the pipeline, it would seem. But actually, you know, the interests should be aligned because we do share a common interest in getting these problems resolved. So, for example, you know, if a regulator modifies its assessment protocols, but HTA agencies and reimbursement authorities downstream still require traditional RCTs and quality thresholds, etc., you're going to run into problems, and innovators will have invested resources in generating evidence that might not actually be accepted at the next stage. So there's challenges of alignment, and I think that often when it comes to, you know, large-scale policy shifts of this kind, we don't pay enough attention to coordination. There's a second specific challenge with professional-facing technologies of the type that we're discussing, and that's, of course, around the outcome measures. You know, we've got established outcome measures for patient-facing technologies, but for professional-facing technologies, it's very different. What exactly should we be measuring here? Diagnostic accuracy, workflow efficiency, time saved, etc. And I want to bring it back to the report here, because the report provides a framework for thinking about these questions, and we very much hope that it'll help to bring around the kind of convergence and standards that is needed. But for now, you know, the uncertainty that's there, it reinforces adherence to current approaches. People are quite risk averse. Obviously, if we get this wrong, the consequences could be really dire. So we need coordination across the pathways. And you know, another of the recommendations that we make specifically around getting multiple stakeholders aligned around piloting and rapid iteration, I think is going to be hopefully part of the solution.
Thank you very much. Thank you very much, George. We hear about we start off thinking about the evidence of impact. Okay, that we need that. It takes time to build, rebuild, and adjust the methods and the protocols to generate this evidence. We need to coordinate these stakeholders to get those protocols in place. Chowie, you have to deal with this on the ground. And then the question becomes, on the one hand, we are ushering in a new paradigm in healthcare, but we keep measuring them using traditional metrics and methods. How do you navigate that paradox on a day-to-day basis?
Yeah, thank you very much for the great question, Robin. First of all, I do want to echo Professor Kluken and Walton. You provided a very comprehensive and insightful white paper and report. Thank you very much for that. To your question, I think the fundamental challenge here is really we cannot measure the dynamic AI solutions with the traditional static RCTs. The old gold standard RCTs are simply too slow and too costly for the iterative digital solutions. We must shift towards a more pragmatic and continuous evidence generation approach. So here it means we embracing the pragmatic clinical studies, real-world evidence, and also simulation-based methodologies. Thanks to the recent advancement of digital twins and also increasing availability of real-world data, these innovative methods now becoming more practical, right?
Thank you very much. And I want to push that point even further by going back to Jochen. I briefly touched on the idea of probabilistic data analysis in the presentation, because rather than dealing with the uncertainty of evidence, we now have to deal with an inherent uncertainty of the technology that we test. And while methodological innovations may be on the horizon, how does evidence how do we deal with this technological level evidence uncertainty at within the clinical community?
Yeah, I think a very important point, and I think we discussed before already that a classical RCT, where you have yes or no answers, is the mechanism of an action of a drug, for example, really working or not, is something that is not comparable to what AI can do. AI will give, in the end, a probabilistic answer. It will say this patient probably benefits from A, B, or C, or we have a new diagnostic information that tells us a probability answer. So in a way, AI itself has a probabilistic character. And now we want to evaluate the effectiveness of AI using classical statistical procedures. And I think that is not really addressing the benefit of AI. And here probabilistically approaches, Bayesian models and others are really something, and you addressed it in your report quite well, are really something that helps basically evaluating these new concepts in a better way. And there's another topic, two topics, and I just want to touch upon them. One is this relearning. AI has a characteristic to continuously learn. Better data, better information is available, and AI will be relearned. So that means you change AI, and you change it. You have to regulatory go through this again, and here you also need to look back into what was our evaluation before it relearned, and then again. So you add basically new information for the evaluation, and that is not, you cannot compare this with classical RCT, and here the probabilistically model to evaluate the effectiveness of AI are also quite important. And last but not least, also the doctor's acceptance. So when a doctor is making a clinical decision, it's a probabilistic decision. The decision itself is yes or no, but it's building on the a priori knowledge of the doctor doing something. And now we have new statistics that basically can address this potential of AI to support healthcare professionals. So therefore, we have to look into completely new statistical methods. To be honest, a probabilistic approach to evaluate AI are actual fundamental part of AI. So I see in the future not only Bayesian models, etc., that can be used for regulatory procedure and increase the acceptance on healthcare professionals because it works similar to what they do. But I also see AI evaluating AI in the future. So that means we really have to completely change our picture of only RCT as a gold standard of evidence generation in medicine.
Thank you very much, Jochen. And this is where I think as the old adage goes, trust but verify. In the context of AI, we can start to reframe that into verify then trust. And it is for that reason that I'm very happy that, and for this I'll go to Antonio, that the World Economic Forum has recently put out a report entitled Earning Trust for AI rather than Building Trust. So Antonio, preceding this LSE Roche report was your report on earning trust in AI, which really underscores the importance of convening public and private sector stakeholders to co-create regulatory assessment HTA processes. Can you give us some insights on what would be likely to happen if we fail to do so?
Thanks a lot, and really enjoying the discussion so far. I think a lot of great points have already been made that I would definitely echo, but I can add a few reflections from the forum's perspective. So I would say first, it's worth remembering that public-private collaboration has always been fundamental to regulation and HTA in healthcare, even without mentioning digital and AI. So there's always been a balance between the constraints that innovators face in terms of needing, to have a business model and needing to get innovations into the market versus the guardrails that we need, which regulators and health systems put in place to make sure that, solutions are safe and cost effective and responsible. But at the end of the day, we have the same joint objective, which is to apply new technology in health to improve, outcomes, access, and efficiency, but to do so responsibly. There there have been a lot of different processes, consultations, and other mechanisms already in the system to drive this, collaboration. But what I think is different today is that the nature of innovation itself has changed. A lot has already been said, but with digital health and AI, life cycles of the technology are continuous, not linear. We see a lot more actors involved in the process, and it's not, very simple. And new kinds of evidence, new rules around data, et cetera. So the whole playing field has sort of changed. And that means the way we collaborate also has to evolve alongside that. So not more of the same, but we actually need new models of collaboration that match these new realities of innovation. So as you mentioned in our report recently on earning trust for AI in health, we emphasized the co-creation of regulatory and HTA processes with things like agile regulatory mechanisms, sandboxes, and modernization of post-market surveillance, alongside structured private sector input across the value chain. So we don't have all the answers, but there are some more details in that report, some of the early thinking. I think it's still early days. But I'm really excited to see that the new LSE Roche report has come out that's going a lot deeper. So we need more of that kind of thought leadership. And to address your question directly, I think if we fail to move in this direction, the risks are quite serious. You really miss then a crucial feedback loop between the different parties in the ecosystem, and you could see regulatory fragmentation with inconsistencies and duplication. You could see misdirected regulation, which actually could be too restrictive, or ironically could be too lax if, say, for example, the private sector and innovators often might know the best technical aspects of the models in terms of what the emerging risks are. So I saw in the chat model drift was mentioned, things like that regulators may have a hard time keeping up with. So ironically, you might end up with too lax regulations in some areas, and also loss of competitiveness. So you'll see different regions tackling this differently, and if some don't kind of crack this balance of how to get innovation into the system with the right sort of feedback loops, they might end up relying more on innovation from other regions and not having that sort of sovereignty. So a lot more to be said there, but I think one last point I wanted to mention is that the bigger risk is tying back to the macro point you mentioned at the very beginning, which is that health systems are under a lot of strain. So there are all those near-term risks, but the bigger risk is budgets are increasing, chronic diseases are increasing, et cetera, and the legacy sort of approach to healthcare is not really able to address those issues. So the faster we can get these technologies scaled up in the right way where they're proven to be effective, the better, because there is urgency here, and often it feels like there's not enough urgency being felt in the system, and we need to kind of push more on that and not ask like whether we should be pushing these technologies forward, but how to do it. How do we work together to make that happen? And so just to close out, at the forum, we are addressing this through our Digital Healthcare Transformation Initiative, or DHT, which is a global public-private platform bringing leaders together, policymakers and industry, to shape this enabling environment. And we are looking at ecosystem shaping in the key markets where policies are really moving forward, like the EU, the US, but also more broadly globally. And I really like what George said earlier. You mentioned the coordination challenge, despite the fact that we have these common goals. And I think that's really what we're trying to do as the forum, is address that. We see that there's more and more dialogue needed. You have coordination across the value chain. So pharma, med tech, providers, tech, et cetera, need to work together in the private sector. Public and private need to work together in jurisdictions. And then you need also collaboration across jurisdictions to try to drive convergence as much as possible. So yeah, I think this discussion today is actually a great starting point for some of that collaboration. You see the multi-sectoral group we have here, but a lot more of this is needed, and really structured mechanisms to keep this going on an ongoing basis going forward. So
Thank you very much, Antonio. And with that, with the mention of public actors, private actors, new actors, old actors, everyone kind of enmeshing into a new paradigm, I want to throw this back to George. At the LSE works with both public and private actors in a very evidence-based manner. What are some of the core guiding principles that you've learned so far that can help ensure a common vision is reached during those convenings?
Yeah, thanks, Robin. So yeah, another great question. And to be honest, I'd probably refer back to a lot of what Antonio just said, because I think it was very relevant. But you're right that you know, here at LSE, as an academic institution, we often find ourselves in a convening role, bringing stakeholders together, sometimes mediating between them. And of course, there is no simple magic solution to bringing stakeholders who have very different starting positions together to align around a common goal. But I think in this case, we have to recognize again, and I know that we've already said this, but it probably is worth reiterating that there are common interests here. You know, the problems that these technologies aim to address, whether it's workforce shortages, you know, delays in access to diagnostics or access to care more generally, geographic inequities, fiscal pressure on health systems. You know, these cut across countries, they cut across sectoral boundaries. And all the participants that would be involved in a negotiation around, say, a new evaluation regime stand to benefit from resolving the current dysfunction, and it is dysfunctional. So whether it's innovators, regulators, payers, healthcare professionals, patients, everybody has this common interest in having a consistent but responsive and somewhat flexible, navigable and fit for purpose, ultimately, a fit for purpose evaluation regime. It's in everybody's interests. And so that would be the first principle, is to identify those areas of aligned interests, which in this case, I think are very broad. So the Venn diagram will have a big central section. But it doesn't eliminate the underlying tensions you might see between stakeholders. You know, regulators will always prioritize safety. Developers are always going to be most interested in, you know, timely market to access, beyond having developed a beneficial technology. Payers will be preoccupied with fiscal budgetary constraints and so on. So it's worth surfacing those tensions and making them kind of visible and negotiable rather than adversarial. The other thing is to ask, you know, what do we really mean by consensus, right? We don't necessarily mean perfect agreement among everybody on every point. What we need is alignment on the really important things, and agreement that the process itself is fair. If we aim for perfect agreement at the very outset, then it's going to be somewhat paralyzing, I would argue. So, you know, we need to make interdependencies explicit, make the trade-offs explicit, make sure they're well understood, and also, I think, commit to this principle of iteration and experimentation. Given that this is such a rapidly evolving field, if our regulatory systems and our evaluation systems aren't equally as rapid in their evolution, then ultimately you're going to see a widening gap between the potential of technology and the extent to which our health systems can actually make use of technology. So, you know, rapid cycles and a responsive approach, and hopefully that will help to bridge the gaps.
Thank you very much, George. And before I'm going to throw it over to Katarzyna to discuss a little bit more these innovations in our regulatory and HTA protocols, I do want to remind everyone in attendance here to please post any questions you might have in our Q&A chat. And if there's already a question there, to make sure to indicate it by liking the question. In the aftermath of today's webinar, we will take the 10 highest rated questions and answer them in a kind of follow-up in a follow-up news post that we will detail slightly more at the very end of the webinar before we close off. Now, back to the panel discussion. Katarzyna, so far we might have been slightly mean towards the HTA innovations or the innovations that are happening in terms of HTA processes. Could you speak to some of the ongoing endeavors that you're part of as part of MedTech Europe and how those sit within the current dialogue?
Yes, of course. So first of all, thank you for inviting me. I think this kind of conversations are crucial to move things forward. And great report, compliments. I think this is really moving the needle on AI value assessment, because we often don't think about the full value of those technologies. And I think this is a big mistake. From my perspective, let me tell you, I've been looking into AI in healthcare for the last 10 years. So when the big hype started, but of course, AI technologies are there for many, many years. And I think this is something that we often forget, because we always think about AI innovation. We always think about how this is going to transform the healthcare. But AI technologies are there for a long time, and we are not fast enough. So I really like, Antonio, your call for urgency. We need urgency. If you think about it, we have around 1,000 AI algorithms with CE mark in Europe right now. 6% of those technologies went through any type of health technology assessment. 6%. And 1% is getting any type of reimbursement. And this is really worrying because we know that AI technologies are being used in the clinical practice. We know that technologies that maybe shouldn't be used because they are not of high quality enough can be dangerous for patients. So we either step up the game and we try to figure out how to deal with those technologies and how to properly assess their value and push into the healthcare systems those that are the most beneficial, or we are going to run into a lot of trouble. Because from my perspective, I think the moment AI starts to make mistakes, crucial mistakes at the clinical sites, the trust is gone. And Antonio, you will have a lot of work to build this trust this again. So that's really a call to action, because in the end, I know that there are a lot of things happening. I mean, if you look at the European Union, we have 27 countries. 5 of them have some nascent steps in HTA for AI and digital health. The rest just doesn't know what to do with those technologies. There is no alignment with regulatory, so there is no transparency on the evidence requirements. I mean, UK, NICE, is doing beautiful job on the evidence standard framework, but this is still very early in the development as well. So I don't know if we, it's even difficult to say what we should be doing in a way that I feel like we are spending a lot of time in panels and, in high-level discussions. But in the end, we have to find a way to move beyond the panels, and we have to find a way to bring the stakeholders together, make alignment calls on what kind of technologies do we have, what kind of evidence are we going to accept for those technologies, and we just have to move things forward. So of course, from MedTech Europe perspective, the industry needs transparency. We need to understand early on, almost at the time when you are basically creating your innovation pipelines, what kind of evidence do you have to create at the idea generation? Because that will determine the budgets for the projects that we are running. And right now it's a little bit, AI algorithm is ready, and then you try to go on the market, but maybe it's going to be accepted or maybe not. So it's a little bit like, Russian roulette. And I think transparency is the key. Transparency is really the key. I think sometimes maybe we have to lower the high standards a little bit. Like, I know that RCTs, we understand and we like the predictability of RCTs, but they are not working for digital. They are not working for AI, because the life cycles of those technologies are much shorter than from mainstream medical devices. So we have to find some kind of agreement on what we are going to do and how do we increase the adoption. So that would be the call from the medtech industry. Also, of course, we are looking into what different projects are doing. So Robin, you mentioned the data, you mentioned SSDHT. I think there is also room for improvement to include industry more in the discussions, because in the end, the industry is always somewhere as the advisory board. We are testing things that are being developed. On the other hand, because the industry is developing AI technologies, we are expected to bring the expertise to increase digital literacy. But when it comes to HTA frameworks, we don't really feel like we are being listened to. So I think there's also a bit of room for improvement in that space.
Thank you very much, Katarzyna. And to move on towards Chawi, if I can come back to you. We mentioned EDITA, we mentioned SSDHT. I believe there's also EVAL EU DMD, and there's a plethora of other initiatives looking to harmonize and to improve these HTA processes. How are these likely to shift the way that you approach evidence generation?
Yeah, absolutely. First of all, I do want to thank you, Katarzyna. You're hitting on the pain points exactly spot on. And also, like Robin, coming back to your question, I listening to all the panelists mentioning all the effort, momentum, activities in this direction. I feel excited, and it's super encouraging. And I understand, due to the complexity, it probably will take a village and take some time for us to get to a harmonized, structured, predictable HTA, which is what I wish for, right? And assuming we get there, I think it will be a game changer for evidence generation, no doubt. First and foremost, coming to Katarzyna's point, it will provide clarity and transparency. Here the innovators will have clear expectations on what evidence is needed when, and this will reduce the wasted effort, avoid the detours, and also late-stage surprises, right? And it will also accelerate the whole process, with clear methodological expectations around acceptable endpoints, comparator, even the role of real-world evidence and simulation-based methodologies. The teams can generate evidence, in a way more faster approach without compromising rigor. Another big benefit I'd like to highlight is also around comparability. Right now, companies often generate different evidence packages for different countries, also for different payers. If we have a harmonized HTA process, this will reduce fragmentation dramatically, right? And evidence will be way more comparable and reusable. And this will also, reduce the duplication, cut costs, and enable the innovations to scale. Not to mention the benefit around the real-world evidence. If HTA explicitly values the data collected from wearables, which I know Professor Jochen, you have a lot of work on in this area, right? And also the data from EHRs and also patient engagement apps, this will provide strong incentives for investment on building robust data infrastructure. And this will shift us towards a more continuous learning health systems. Finally, it will also center patient. The modern HTA increasingly emphasize the outcome metrics that matters to patients, including the life quality, including the accessibility, and also accessibility, right? And this will really move our evidence generation beyond the technical performance towards really what truly improves the care. So in essence, I think like having really like predictable, structured, harmonized HTA is not just only about the smoother reimbursement. It is really about having a smarter, faster, more patient-centered evidence generation to help the best digital health solutions reach the patients sooner.
Thank you very much, Chowie. And I mean, I believe all people here on the panel are somewhat to various degrees in alignment on what has to happen. So to kind of compact it all with a nice big bow on top, George, can I ask you to summarize? On the one hand, we heard what needs to be done in the policy realm. On the other hand, what needs to be done in practice. However, in the middle, we have a health system that faces significant pressures, whether it's fiscal, growing burdens of diseases, or just apathy in some cases. How can we help policymakers and other stakeholders identify what needs to be done versus what would be nice to be done?
Okay, thanks, Robin. That's a really, really tough question, and frankly, trying to summarize what has been a really very rich discussion, I think, is also a very high bar for me. But just focusing on the question of evaluation processes and the full spectrum of requirements across the process. If you were to kind of distinguish between what might be nice to have and what would be, absolutely essential, the things that are essential are going to be those interventions that address like structural problems that create institutional capacity for the evaluation and adoption of technologies. And ideally, these should integrate entire classes of evolving technologies systematically and sustainably rather than just individual technologies, right? And I'd like to go just one step further, I think, than Xiao Hui in her last comment about having systems that are able to accept and take up technologies, right? Because we have to remember as well that our regulatory systems send signals to innovators, whether they're in the private sector, whether they're in academic health science centers, about what kind of innovation is needed, wanted, welcomed, as well as just sort of what will be accepted, right? So our regulatory systems are going to shape the health systems of the future, not just through what they accept, but also, accepting that creates strong incentives among innovators. So this is a crucial question. And then I'd like to bring it back to the report again. You mentioned in your opening presentation, Robin, about the importance of having functional classifications, right? And I think this is going to be a prerequisite. This is going to be one of those necessities, because we've got different actors describing the same technologies using incompatible frameworks, regulators using risk-based classifications, HTA agencies using function-based categories, and so on. Clinicians thinking clinical workflow terms. This makes coordination extremely helpful, right? So the framework that we provide, the taxonomy, includes like 7 different dimensions. And again, I'd like to direct people's attention towards the report. I think the link to it should have been shared in the chat now, because one thing that is definitely going to be needed is like the shared language, a shared understanding of exactly what it is that we're evaluating. Otherwise, we're going to have actors continuing to talk past each other. The next thing, of course, is for the evidence standards to be aligned with those functions, with those use cases. So it's not ideal to use a framework designed for pharmaceuticals, for a technology that enhances the workflow within a clinical directorate of a teaching hospital, right? Just fundamentally different. The evidence standard should reflect that. We've already talked about institutional alignment across all of these pathways, and I think that is also going to be necessary. The question is, who's responsible for that, right? If all of the actors involved recognize their shared interest in this, we can hope that it might emerge organically, but those that have the means to convene, the energy and the wherewithal should invest in that. And, I'd like to think that a panel discussion like this is quite a good example. Then, of course, you've got the methodological approaches, actually suiting them to technology characteristics. And Professor Klucken has already spoken very well about this too, so I won't expand on it much more. And yeah, everything else that has been mentioned as well, multi-stakeholder co-design and iteration, equally important. So all of these things are needed. These are systemic factors, right? Shared language, aligned processes, appropriate methods, etc. These are the foundations. We need to strengthen every link in the chain, and if we don't, then the process is only as strong as its weakest link, if you like. So we need to do all of this. Anything that might be considered a nicety, these might be things that offer kind of incremental improvements to individual elements, right? Incremental improvements to individual elements. Those individual elements might not be systemic bottlenecks yet, but they will be eventually. Once we've got the fundamentals in place, those niceties will become priorities, because it should be a process of continual improvement. But let's get the structural factors right, and then refine and enhance. I hope that sums things up.
Thank you very much. And I could not have given a better summary of today's panel discussion myself. Ultimately, these new technologies are challenging the way that we are approaching evidence generation, technology evaluation, and ultimately healthcare delivery and deployment. I want to thank each and every one of you very much for being here on this panel with me today. And to round off the session, I want to bring it back to our host, Afa van Hasteren. Thank you very much.
Thank you, Robin. Thank you all so much. And for those of us, and those of you online that stuck with us, thank you. I see that the numbers have dropped significantly, but that's par for course, because we're getting to the end of the session. I think that hearing the statistic that Katarzyna shared is a bit grim, right? We have about 1,000 algorithms that have undergone CE mark, and only about 60 of them have gone through any evaluation process. I think if there's any statistic that sort of highlights the urgency with which we need to get this process started, I think that will be it. Once again, thank you so much to panelists for accepting our invitation to join, and my colleague Chao as well for all the support throughout this process. Thank you as well, everyone online. We will share the link to the report in a follow-up email. As well as an answer to the top 10 questions. I can see that some are also sort of dedicated to specific members of the panel. We'll get those addressed. And so please don't hesitate to reach out to any of us if you have any questions, whether it's on LinkedIn or individually. Thanks so much again, and I wish you a lovely rest of the day. Thank you.
Thank you. Bye-bye.
Thank you.
Bye.
Sure. Thank you.